Hi everyone, this is Dr. Priti Avari. Today we are going to see anatomy of the scalp. First we will see extent of the scalp. So scalp is extending from eyebrows in front to the superior nuchal lines behind on the occipital bone, and laterally it extends till the superior temporal line. So scalp includes even the area of the forehead. Now we'll see the layers of the scalp. The S stands for skin, C will stand for connective tissue, which is dense type of connective tissue. A will stand for aponeurosis and flat muscle called as occipitofrontalis muscle. So this green color represents the aponeurosis here. Deep to that there is fourth layer. L stands for loose areolar tissue. Deep to that there will be our skull bone. So the periosteum covering the skull bone from outside, that is called as pericranium. P for pericranium. This is the fifth layer of the scalp. We are going to see all layers in detail with anatomical basis for development of various kinds of entities in relation with scalp. We will start with skin of the scalp. The texture is very thick even though it is a thin skin or hairy skin. We can see abundant of number of hair follicles and sebaceous glands in this region. So, formation of sebaceous cyst is quite common here in the scalp. So, in this picture, you can see the sebaceous cyst is shown here. The sebaceous gland, its duct will open into the hair follicle. So, sometimes this duct is occluded and the sebum gets collected within the gland and it swells out. This is called as sebaceous cyst. Sometimes it is too large that after some times, if it is not treated, it can give rise to something called as sebaceous horn. I had seen a patient with sebaceous horn when I was doing my internship. The second layer is connective tissue layer of the scalp, which is the second layer of the scalp. But even though it is a superficial fascia, here it is made up of densely arranged fibers. So it is a dense layer. Plenty of fibrous strands break up this layer into compartments as locules. So in this picture you can see there are vertical fibrous strands dividing this layer into compartments. The vertical fiber strands connect dermis of the skin to aponeurotic layer. So dermis here is connected with the aponeurosis below with the help of these strands. Hence, it is difficult to remove skin from the aponeurosis. This layer contains nerves and blood vessels of the scalp and it is having rich blood supply. So you can make out in the locules the blood vessels and nerves are present which are innervating to the scalp and supplying blood to the scalp. Open wounds of the scalp bleed profusely. Why? The vessels which are cut during an injury are unable to retract as their walls are adherent to the fibrous strands. Bleeding can be stopped by pressing against the underlying bones. Here, the tunica adventitia of the blood vessels merge with the fibrous connective tissue. So, it is very difficult for the open ends of the blood vessels to retract. It leads to bleeding. At the same time, wounds of the scalp heal early because of more vascularity. Closed hemorrhage in this layer is never too extensive due to densely arranged fibrous strands. So if you see the swellings of the scalp, even though there is collection of more amount of fluid or blood, the swelling will not appear that big. This is because of the dense arrangement of the fibrous strands. Swelling in this layer are often very painful. Why? Because of unyielding nature of the fascia. That means the connective tissue layer cannot expand as collagen fibers cannot lengthen because of lack of elasticity. At the same time, the Scalp is innervated by more number of nerve fibers, so swellings in this layer are very painful. Now we will talk about the third layer. This is the occipitofrontalis muscle and gallia aponeurotica. So in this slide you can see two pictures. In the first picture we are showing a muscle here, the frontal belly, and in the second picture you can see two bellies in front, two bellies behind. So in front there is frontalis, behind there is occipitalis, and in between connecting these two muscles there is a thin sheath of tendon called as gallia aponeurotica or epicranial aponeurosis. So in the third layer, first we will see the frontal bellies. What is their origin? They will originate from the skin and subcutaneous tissue over the eyebrows. So it is not attached to the bone beneath. The muscle fibers are running behind, as you can see. They are covering the forehead and passing towards the gallia. There is no bony attachment. They insert into the epicranial aponeurosis just in front of the coronal sutures. Suppose this is a coronal suture, so just in front of that, these fibers are inserting into the aponeurosis. Frontalis is innervated by temporal branch of facial nerve. The second is occipital bellies. So behind two occipital bellies are present. They arise from lateral two-thirds of the superior nuchal lines in the occipital bone. So here you can see these are superior nuchal lines, and this muscle is originating from the superior nuchal lines. As the muscle goes up in front, it inserts into the epicranial aponeurosis. These bellies are innervated by posterior auricular branch of facial nerve. In the third layer, now we will talk about the aponeurosis, gallia aponeurotica, also called as epicranial aponeurosis. This is made up of flat tendon of occipitofrontalis, which takes the shape of vault of the skull. On side, it is attached to the superior temporal lines. Behind, it will be attached to the, you can say, highest nuchal line or superior nuchal line. This layer cannot be separated from the skin of the scalp. Now, what is the action of this occipitofrontalis? Alternate contraction of both muscles will do forward and backward movement of first three layers of the scalp on calvaria. Now, what is the action of frontalis? Acting from above, it can raise the eyebrows. Acting from below, it can produce horizontal wrinkles on the forehead. Let us talk about something called as surgical layers of the scalp, as in this picture shown. The skin, dense connective tissue, and gallia aponeurotica. They are adherent to each other. They form a single thick layer which moves on the vault of the skull. This is called as surgical layer of the scalp. They can form the scalp flap used for grafting. The flap of the scalp should have a pedicle at periphery where the blood vessels enter in the scalp. Now we can see gaping of the wound. That means we can see a gap in the two lips of the wound only if these three layers are cut transversely. So when we are taking cut from right to left side, then only we can see there is a gap in the wound if all three layers are cut together. Only the first layer, only if the second layer is cut, we can't see gaping in the wound. Now we will see the fourth layer, that is loose connective tissue layer of the scalp. So this is the loose connective tissue layer which is made up of loose areolar tissue. What is the specific feature of this layer? This layer contains emissary veins connecting veins of the scalp with the dural venous sinuses in the skull. So these are the veins of the scalp in second layer, and we have shown one dural venous sinus. This is actually the mid sagittal, superior sagittal sinus. Connecting them, a vein is traveling through this fourth layer. This vein is called as emissary vein. So lots of emissary veins will be present in the fourth layers, which are carrying blood from the veins of the scalp to the dural venous sinuses. What is the applied aspect here? The emissary veins are potential dangers to carry infections of superficial wounds of the scalp to the dural venous sinuses. So, the bacteria can travel from the veins of the scalp to the dural venous sinuses through these ep- emissary veins, and that can lead to infection of these dural venous sinuses and later on thrombosis of the dural venous sinuses, and which is very difficult condition to treat. That's why this layer is also called as dangerous area of the scalp. Now, along with the fourth layer also has got some other applied aspect, that is black eye. Let us try to understand what is black eye. Black eyes can develop, that means we can see the reddish discoloration, bluish discoloration, greenish or black discoloration of the upper eyelid and lower eyelid after injury to the scalp or the forehead. It develops because of extravasation of the blood into the subcutaneous tissue and skin of the eyelids and surrounding area. So, there is a condition called as indirect black eye, which is associated with the fourth layer of the scalp. What is it? Bruising around the eyes that occurs due to injury away from the eye with blood breaking into the eyelids. So there is no direct blow to the eye, or there is no direct hit to the eyelids or trauma to the eyelids. The injury has occurred somewhere in the scalp above, and the blood which is collected in the fourth layer, it is tracking down into eyelids. The cause could be trauma to the forehead or scalp, or there could be fracture of the skull bone. What is the mechanism of formation of this? Blood collects into the loose tissue and it gravitates down to the eyelids as the frontalis is not attached to the frontal bone. So there is a gap present between frontal bone and frontalis muscle through which the blood is trickling down. The specific feature is the indirect the eye develops hours to days later the injury. Maybe after 24 hours it will develop. Less local pain is present over the eye. The patient won't say that I am having pain around the eye or in eyelids. The bruising will be often very diffuse. First, it will involve upper eyelid, then, it will involve lower eyelid, and it could be bilateral if there is too much bleeding. Now, what is exactly happening here? Let us try to understand. The gallia aponeurotica and occipitalis pellis are attached to the superior nuchal lines in the occipital region. You can see behind there is no way for the blood to gravitate down below the superior nuchal lines. The gallia aponeurotica is also attached to the superior temporal lines on both sides. So on both sides also the blood can't gravitate into the temporal region. The frontalis pellis are not attached to the superior superciliary arches. So in front, in the third diagram, you can see I was not able to draw the brown colored muscle here, but let us try to assume that frontalis muscle is present here. So this frontalis is not attached to the frontal bone or superciliary arches. So there is a gap present in between. Okay. So hence the loose connective tissue of the scalp is in continuity with the loose connective tissue of the eyelid. So the blood gets way to gravitate in the eyelids. So same is shown in this big diagram where you can see the loose connective tissue, blood is collected in this tissue and it can't go laterally, it can't go behind, so blood is trickling down in front underneath the bases of frontalis so that it can enter into the loose connective tissue of the upper eyelid and after some time into the lower eyelid. Now that was the indirect black eye. Now what is direct black eye? There will be direct trauma to the eye leading to bruising around the eye. And here, the patient will complain of pain and tenderness at the site. The swelling will appear immediately. The bruising will be confined to area of impact, and this might be associated with the injury to the eye. So we should know the difference between direct and indirect black eye. For us, what is important here is the direct black eye is due to direct blow to the eye. Indirect black eye is developed because of there is some blow on the head with the blunt object. So the indirect black eye will be medico-legally very significant. The patient will also say that he develops he had developed the black eye not immediately, maybe after 1 day, maybe after 2 days. In direct black eye, the patient will say it developed within half an hour. So indirect black eye is medico-legally significant. We need to inform to the police because there is some suspicion of some kind of assault. So we have finished with the fourth layer. Let us talk about the fifth layer. This is actually the connective tissue covering the flat bone periosteum. So this is the periosteum, also called as pericranium, underneath the loose connective tissue. The applied aspect here is formation of a swelling underneath this periosteum called as cephalhematoma. Because of some rupture to these veins which are traveling through the bone, sometimes blood gets collected underneath the periosteum. This will take the shape of underlying bone and it will not cross the suture lines. So it will exactly take the shape of, let us say, occipital bone or parietal bone. Now there are three kind of swellings which can develop in the scalp region called as caput succedaneum, cephalhematoma, septivalve hematoma. Now this is a beautiful diagram which is explaining the same. Caput is developing into the second layer of the scalp. Cephalhematoma is developing in the fifth layer of the scalp, and septivalve hematoma is developing into the fourth layer of the scalp. We want to see the anatomical basis of formation of these swellings. First, cephalhematoma. So there is occurrence of hematoma deep to the periosteum. So yellow colored is actually the bone, flat bone. You can say diploe and the outer table, inner table are shown. And above that, you can see underneath the pericranium, there is collection of the blood. Location is subperiosteal between the skull bone and the periosteum. The reason is rupture of vessels during delivery of the baby. So this could be seen in the neonate. The very important feature is this swelling will not cross the suture line and it will take the shape of underlying bone. It appears hours after birth. The consistency will be very firm and well developed swelling, well defined swelling. It can lead to jaundice. There might be formation of jaundice because of some kind of injury. Second is septivalve hematoma. What is it? Let us try to understand. The location is subaponeurotic, just underneath the gallia aponeurotica. So, in the fourth layer, dangerous area of the scalp, loose connective tissue, there is formation of diffuse swelling. Okay, what is the reason? This is the emissary vein connecting the blood vessels in the second layer with the dural venous sinuses. So, these emissary veins are ruptured. Okay, so that can lead to accumulation of the blood. Now, the second layer and the third layer, here there is no space for the blood to accumulate. They are made up of densely packed connective tissue, collagen fibers. So, which is the layer where the blood can get collected? Only the loose connective tissue. The onset is very gradual. The danger is the blood can accumulate to the large amount, extensive accumulation of the blood, and it will take time. So, what is happening here? There might be hemorrhage inside also. There might be extradural hemorrhage here, and the hemorrhage has entered into the third layer through the emissary veins. It has entered into the fourth layer through the emissary veins, and after that, patient might come after 1 day, patient might come after 2 days after development of the swelling, but before that, it might have led to compression of the brain inside. So that's why it is life threatening. Why the name safety valve? It prevents increase in the intracranial pressure. Maybe in first day, second day, there won't be increase in the intracranial pressure. So you will get time if the patient is coming immediately. So this communication between the dural venous sinuses and the fourth layer, it acts as a safety valve here. That's why the name safety valve hematoma. This is also called as subaponeurotic or subgaleal hemorrhage. The third very important entity which is quite common is caput succedaneum. What is it? Swelling in the subcutaneous tissue, the second layer of the scalp. The very common reason is pressure during vaginal delivery. So during vaginal delivery, the head could be the presenting part. The vault could actually the vault of the skull should be the presenting part, and it gets compressed around the external os. So that can lead to formation of the swelling because of accumulation of the blood. Here the key feature is the swelling has crossed the suture line, and immediately after birth you can see the swelling. It will be soft pitting edema will be present, and it will immediately resolve within few days. So it is not at all dangerous. So in this picture you can see development of the swelling in the second layer. So this is the skin above and this is the gallia aponeurotica. In between you can see the collection of the not blood exactly. It could be any kind of fluid. This will be transudate most of the time, and it will be resolved within few days. That is caput succedaneum. This is a beautiful picture. You can draw this to show the location of these swellings. Like cephalhematoma will be seen just above the skull bone underneath the periosteum. Safety valve hematoma can be seen in subaponeurotic space, and caput succedaneum can be seen into the subcutaneous tissue of the skin. Nerve supply of the scalp. Scalp is supplied by supratrochlear nerve, supraorbital nerve. These are the branches of frontal nerve. Frontal nerve itself is a branch of ophthalmic division of trigeminal nerve. So these two nerves indirectly are branches of ophthalmic division of trigeminal nerve in front. Behind it is supplied by zygomaticotemporal nerve, auriculotemporal nerve. Zygomaticotemporal nerve is a branch of maxillary nerve. Auriculotemporal nerve is a branch of mandibular nerve. So these four nerves are supplying, giving sensory nerve supply to the scalp. In between them, you get a branch of facial nerve, that is the temporal branch of facial nerve. This is a motor branch, will be supplying to frontalis balis in front. Behind the ear, scalp is innervated by greater auricular nerve, posterior auricular branch of facial nerve, lesser occipital nerve, greater occipital nerve, third occipital nerve. Here, the posterior auricular branch of facial nerve is the branch which is innervating to the muscles of the ear and occipitofrontalis balis. So this is only the motor branch. All other are the sensory branches coming from the cervical plexus. You should be able to remember their root values, can be asked in MCQs. Arterial supply of the scalp. In front of the ear, scalp is supplied by supratrochlear artery, supraorbital artery, superficial temporal artery. Superficial temporal artery is a branch of one of the terminal branches of external carotid artery, and these two, supratrochlear, supraorbital artery, they are the branches of ophthalmic artery. Behind the ear, there are two arteries supplying to the scalp, posterior auricular artery and occipital artery. They are branches from external carotid artery. I hope you understood the topic. Thank you for watching. Please like, share, and subscribe. Thank you.